This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG LaFredo. When you think of our community hospital, it may occur to you that we are the largest healthcare provider in Northwest Arizona, with over 1,900 employees. You might think of our general practitioners, our wide range of specialists, and the impressive medical technology they use. But did you know KRMC is also a teaching hospital with thriving residency programs in family medicine, emergency medicine, pharmacy, and research? In this episode, we'll learn more about research at KRMC, who is involved, what they're studying, and what they are working to accomplish. We'll also get to experience a bit of research out loud. For more on that, here is Diana Lalitsasivimol, PhD, Manager of the Office of Research and Sponsored Programs at KRMC.
Research Out Loud is a brand new speaker series hosted by KRMC's Office of Research and Sponsored Programs. Our mission is to cultivate an environment of evidence-based practice through the generation of high-quality research. Research Out Loud offers a platform for students, residents, and fellows who want to share their research and knowledge to drive innovation and excellence throughout the organization. Who are these research fellows? The Kingman Area Research Consortium, or CARE Consortium, has many partnerships with schools across the United States. Within Arizona, we work with places like Midwestern University and the University of Arizona. Outside of Arizona, it can be as close as Roseman University over in Henderson, or as far as Pacific Northwest University in Washington to Michigan State University. So how do they come to KRMC? Medical students and residents may choose to do a research rotation at KRMC and work with a faculty advisor. For the fellows, it is a competitive process where medical students have to develop and submit a research proposal to a review committee, such as to the Arizona College of Osteopathic Medicine or to the Foundation of Osteopathic Medicine, and winners get to do research at sites like ours. So what do they do during their time here? Step 1 is completing human subjects research training. Training is crucial for protecting participant rights and welfare by educating researchers on ethical principles, regulatory requirements, and best practices for informed consent, privacy, and risk minimization. The next step is to refine their research proposal, clarify their primary and secondary objectives, and develop a data collection plan. If their revised proposal is approved by the KHI Institutional Review Board, they can start collecting data. They work with the statistician on data analysis, and then the final step is sharing their information. Upon completing the rotation, they continue to work with their mentors to incorporate feedback and finalize their research project, which may culminate in a talk like this one, a scientific abstract for presentation at a national conference, or a manuscript submission to a peer-reviewed journal. Our trainees do get access to patient records, so you might be wondering, how do we protect patient privacy? Well, confidentiality, security, integrity of data are maintained according to established hospital policies. Only authorized research study personnel have access to the research data. The collection of information about participants is limited to the amount necessary to achieve the aims of the research. The data is de-identified, which means that identifiers are removed from the health information. The data cannot be linked back to the person from whom they were obtained because the information does not contain direct identifiers. This mitigates privacy risks to individuals and also supports the secondary use of data for comparative effectiveness studies, policy assessment, and other endeavors. The electronic data is encrypted and stored with appropriate electronic safeguards. The trainees also take training on information privacy security. IPS covers the principles of data protection, focusing on healthcare-related privacy and information security requirements of HIPAA and the educational records and data-related requirements of FERPA. The research rotation is an elective for our medical students, residents, and fellows. The research rotation is designed to foster the development of research skills and deepen understanding of the scientific process, with the expectation that they will contribute to scientific publications and presentations. A track record of successful presentations at local, national, international meetings is important for trainees to develop a reputation. They often lead to interesting and fruitful networking and collaboration opportunities. They also help with promotion in academic medicine and can reveal new job opportunities. So why is research important to an institution like KRMC? Well, research is the driving force behind progress and innovation. Investing in research is important because it improves patient outcomes, drives innovation in treatment and technologies, enhances patient safety by identifying risks, and provides evidence for better healthcare policies and practices. It leads to new and more effective treatments, helps diagnose diseases earlier and more accurately, and ensures that treatments continue to be both safe and effective.
So that is a bit about Research Out Loud. What topics are our student physicians researching? Well, we don't have time for their complete presentations, but here is a sampling of some of the topics we've heard over the last few months.
Hello everyone, my name is Yusuf Sarama. I'm a second-year student, medical student at the Arizona College of Osteopathic Medicine at Midwestern. I'm also a CAS fellow, and over the course of my 3-month fellowship, I worked on my project, which is titled Pulmonary Embolism Outcomes based on ED disposition and readmittance in a rural U.S. population. First off, what is a pulmonary embolism? So pulmonary embolism is a blood clot, usually starting off in the legs or lower extremities. It breaks off, travels up through the venous system, through the heart, and into the lungs, where it gets trapped. And when this happens, it blocks blood flow to the lungs, so the blood does not get oxygenated, 1. And 2, the parts of the lungs that are blocked do not get any nutrition. And ultimately, this condition can be fatal if not treated promptly. The first question you want to ask is the patient hemodynamically stable? If the answer is no, then they're automatically upgraded to a high-risk pulmonary embolism.
Well, hello everyone. My name is Jacob Barnard. I am a DO student at Midwestern University, Arizona College of Osteopathic Medicine. As previously stated, I am a Kenneth A. Suarez Research Fellow. I've been conducting my 3-month-long research project looking into hip fracture outcomes based off time of admission. I'll be presenting to you guys my project titled Retrospective Analysis of Hip Fracture Outcomes based on the weekend effect in a rural hospital setting.
Hello everybody, my name is Kirit Sura. I am a second-year medical student at Arizona College of Osteopathic Medicine. I'm the 2025 Foundation of Osteopathic Emergency Medicine Fellow, and I did my project in collaboration with Kingman Regional Medical Center looking at a retrospective analysis of central line complication rates in a rural community setting.
Hi everyone, my name is Madison Gackle. I am a second-year medical student at Midwestern University's Arizona College of Osteopathic Medicine. I am here today with the Kenneth A. Suarez Research Fellowship, and we did this project in conjunction with Kingman Regional Medical Center. Today I am presenting my topic of assessing treatment compliance of skin and soft tissue infections to published guidelines.
My name is Riley Johnson. I'm a third-year medical student at the Arizona College of Osteopathic Medicine. I spent the last month here at Kingman Regional Medical Center with my partner Yana to evaluate the adherence to Choosing Wisely guidelines, a retrospective review of chest radiograph and viral testing in pediatric emergency respiratory cases.
All right, so my poster presentation is on publication characteristics of successfully integrated plastic surgery residents from 2018 to 2023.
If you're just joining us, this is Focus on Your Health. I'm TG LaFredo, and this week on the program, we're talking about research at Kingman Regional Medical Center. Medical students and residents come to KRMC to work in the Office of Research and Sponsored Programs, immersing themselves in research projects that hone their analytical skills and improve our hospital. For more, here's Dr. John Ashurst. He works in emergency medicine, he's an educator, and he serves as the research director.
So what we're trying to do is make sure everyone is kind of aware about what we're doing. So research-wise, we do a lot here. We do a lot in both clinical research and also on the sponsored side, doing a lot of stuff for the community. So we want to make sure that we're getting our products out there. So one of my roles besides here is also working at ASCOM. So I have a research lab at ASCOM. We have a lot of students, and they then transition to our research lab here. So disclosure, so I have to always say this, I'm an author for hire for evidence-based medicine. Anyone wants to read my stuff, I talk about PEs and hyper K and stuff like that, and soon to be acute coli. All right, so the overviews of our 2 labs. So the one on the right is the one we do at ASCOM. So basically what I do is I give them an introduction to evidence-based medicine. Like the basics of research techniques, basics of stats. We go over sensitivity, specificity, how to calculate those things. How do we critically appraise journal articles? And then we transition into doing basic research. So how do we collect data? What we know coming in before, med students had to take basically research classes. They had to take stats classes. As schools have changed, that also has changed. So now they don't come in with that stats background anymore. So what we do to teach them how to do research is we start with publicly anything that we can pull from the internet. So can we look at the NIH stuff? Can we look at the stuff from MIT? So anything that we can get for free. And we start to collect data on those to kind of see what projects they might want to do. And all the research that I do at ASCOM, it's student-led. So they come to me usually with an idea, or I give them like a pitch, and then they start to figure out what they might want to do with that. Here up in Kingman, so we basically teach the application of evidence-based medicine, more advanced research techniques, working on clinical data, so actual patients that we see here. And we try to figure out problems for us here. So that's the big difference. We, from the two labs, we train them how to do stuff down at ASCOM, and then here we train them how to answer questions. Our research up here is more hospital-led, it's more staff-led. We have a lot more support up here. Down there, it's just me. I'm running a lab with just me. So, but up here, we have help. So looking at the outcomes, so over 3 years, I've down at ASCOM, I've had 101 students, roughly, give or take, that I claim, that have been with me for my research lab elective. I've had 2 research interns. Basically, they do a gap year between MS3 and MS4 with hopes of boosting their applications to get into a really competitive specialty, like neurosurge, plastics, ortho, something like that. We've had 163 abstracts that we've presented in that 36 months. We've won numerous awards. I think we've had 25, actually last night I got one more, so we now have 26 articles, which is super, it's from a lab standpoint, you typically don't see those numbers, right? That is, we're publishing 8 a year, doing 50 abstracts a year. Most labs don't do that. They might do 5, they might do 4. So we're doing lots of stuff. We've won state, national awards. We've won international awards. From here, because they don't have the volume, we still take, about 10 students a year during that time period. They've had the CAS people, so we've had 6 of them that come up with us for a summer month. The CAS, or the FOEM interns, they spend 8 to 10 weeks with us, and they design their own projects to come up here just to be with us and learn how to do research between the MS1 and the MS2 years. Numerous abstracts, numerous manuscripts, and again, we've won multiple state, multiple national, and international awards. So I'm going to talk about the current projects I have at ASCOM, things that we're finishing up, just so you can kind of highlight what we do. So, this past year's lab group really wanted to look at COVID stuff. So we got the CMS sets, has 3.3 million individuals in it. From a hospitalization standpoint, things that we knew is what we found. The elderly, males, minorities, they all increased likelihood of being in the hospital, increased LOSs, increased mortality. But when we looked at the splits of rural-urban, that didn't pan out. So what we thought we were going to see is places that were considered rural were going to have longer length of stays, higher mortality. But we actually did not see that. We also looked at nursing homes. So in this set, we have the general individuals and we have the nursing homes. So in the nursing homes, there are temporal trends. So what we should know, so Adam, we should see is in the fall, winter, you're going to see more COVID cases from the nursing homes. Especially in that 2-week period between Christmas and New Year's, that's whenever we see that biggest spike actually. And it's not variant dependent. When we mapped out the different ones like alpha strain, all those ones, it always peaks at the same time. So in the fall, winter, that's whenever we're going to see those big spikes. From the nursing home, when the staff gets a vaccine, there's a 2-week decline in the number of individuals who have the illness at a place, and the staff cases predict the cases seen in the nursing home. So kind of what we thought is that it's not the nursing home residents spreading it amongst themselves, right? It's actually people coming in from the outside who brought COVID into the nursing homes, and that's how then it spreads. And it's pretty linear on what that looks like. Some of the other things, we also saw that I thought it was going to be in specific regions, right? But it's not. It's heterogeneous. So we look at the Northeast, we look at the Southwest. they don't necessarily match. So the exact trends are not the exact same for different areas. All of our peaks are where we would expect them, winter, fall, for the different areas. But the strange thing that we see is that it goes from east to west. So things we're seeing on the East Coast, we should know within a couple months we're going to see them on the West Coast now. And that's pretty every single year. It looks the exact same. It's like the Northeast, the South, then the Midwest, West. So that's just kind of how it's seen. For Arizona, so we also looked at state specific. I'm only going to give you Arizona stuff. We did Arizona, New York, Texas, California, Hawaii, Alaska. In Arizona, the numbers look not the same as the national. So for the vaccines, it's only in 2023 that we see that protective thing. However, the staff cases still strongly are with the cases in the nursing home and higher rates of having the vaccine decrease mortality, right? So that's in Arizona specifically. COVID-19 spread, so we actually also tried to figured out whenever people travel, right? So I go back to like the Walking Dead, right? So they're on that plane and one person gets it and then they give it to someone else, and then it crashes and all those things, right? So we thought so with travel, that's how diseases are spread internationally. What we actually saw is that with air travel, it's not related to spread, right? With more air travel, it was not related to spread. We also looked at big metropolitan areas, and with increased travel in like transport, like taxis and things like that, there was not an increase in spread. But it's probably confounded because there's so many cases. So back whenever we weren't traveling, there was still a lot of cases, right? But then when we started traveling, the cases went up so it's probably related to the case numbers. It's not necessarily travel related, but it's kind of an odd thing that we didn't find that, but it's most likely related to how rapidly we began to retravel. So the team is actually looking at those months where we were in lockdown to see what happened and how COVID spread during those months when we were in like that true lockdown, that 1 month, 2 month period, to see if that stopped the spread as compared to other interventions. For doing the telehealth stuff, so that's one thing that I helped here. So I really wanted to examine that. And what we know is that there was a rapid uptick in the usage of it and more providers using it. However, the people that we needed to use it weren't able to, the elderly, right? So that's who we should have really been looking for. So this kind of tells us that, like the elderly have a hard time with using this services. And a lot of them didn't even know that we were off, that we had these things. So we looked at this from also these things, and it's like 65 and above. When we get to that 80 and above, it's really bad. Like they have a really hard time using technology. So that's one of the things moving forward that we need to build an infrastructure to help out specific groups of individuals. So MLB stuff. So we worked on a lot of MLB stuff. Especially we're the first to present this before the MLB did. So we presented it at OMED last year before the MLB published their results in Sports Illustrated. So the UCL injury, so when you throw curveballs and stuff, you can get injured. Everyone thought, and it was a lot of high impact players. So everyone was super worried that all these million individuals that were getting hurt so often. They thought it was because of the institution of how much time you had to do stuff. It's not. It's not related to timing of the pitch. It's not related to sticky substance bands. It's not related to right-handedness versus left-handedness. It's how hard you throw for how long you throw. Especially we look at Skeens, right? So he's one of the top MLB individuals right now. He throws 100 mph an hour, right? And he goes deep into games because the Pirates aren't very good. So he carries the team. So at some point, more than likely, which we were trying to build a model to figure out when will someone get injured. How many hard throws will it take for that individual to reach the tipping point where it's more likely for that person to become injured. We're now looking at the NFL stuff. So with the increase in injuries like the knee, Achilles, trying to figure out, is it related to maybe the position? Is it related to the stadium, right? So that's one of the things that's come up, is that it could be that these injuries might be related to turf. So is it actually due to turf, or is it some other thing out there? Concussions, we're also looking at to see the recovery. How long does it take for a quarterback to come back? How long does it take for a wide receiver to come back? When they come back, how are their stats that next game beforehand, right? So there's a little bit of hard things in there that we have to account for, like, are you playing against a really good team? So we're trying to figure out ways to come up with that model right now. Getting into a competitive residency is really hard. When you want to get into an ultra-competitive residency, neurosurg, plastics, vascular, ortho, ENT, it's even harder. And research is a big component to your application. So to get into ortho, we'll say, you have to have 29 pieces of scholarly activity on your application prior to applying. Plastics is like 30, I think it is. 28.7, okay. So you need to start doing research really early. And what we saw is over time, so before the board exam for us was scored. So when I took my test, I got a score. And at some point in the last few years, they stopped doing that. It's either, yes, you passed, no, you didn't pass. So we used those scores previously to determine what specialty you got, right? So now that we don't have that, we're looking at other things. So research is one of those things that we look for. And over that period of time where now we're not scoring those tests, then the sheer number of scholarly activity you need, it's gone up. And it's more pronounced if you want to go to a university-based, an academic program. And the individuals who come from NIH top 20 schools have so much stuff. And then some of these other ones that we're doing, right? Lots and lots of projects that we're working on here in Kingman. As we're continuing to grow, we're building more clinical research, more things that will help the patients, more things that will help the hospital. Things that you'll see moving forward that we may be implementing in your departments based upon the results that we find, right? So if we come to you and be like, hey, you should think about doing this, it's because we looked at it and it's probably the best thing to do. I'm currently working on some AI tools, basically to diagnose AFib versus VTAC versus SVT. AI research is hard. You have to train the AI models, so it takes a very long time. We're also looking at behavioral health, the comprehension and compliance with instructions. Maddie's looking at neck FASH, looking at clearances. So there's lots of stuff that we're working on. Some stuff which could potentially change medicine, how we practice, like AI we know is one of those things. Things that will change medicine as a whole, or things that will just hopefully change things here. But we want to get you guys involved, right? So we can come up, the team, we can come up with projects, we can come up with grants, but it helps if you guys give us some things too, because we want to help you. That's what this is about. It isn't about like us just doing research and winning awards, right? It's about the patients. It's about the hospital. It's about improving the care that we give. Sound good?
That's Dr. John Ashurst speaking on the state of medical research at KRMC. My thanks to Dr. Ashurst, to Diana Lalitsasivimol, PhD, and to Anthony Santarelli, PhD, as well as the entire team at the Office of Research and Sponsored Programs. I hope you've enjoyed this report on the work they are doing and its implications for improving medical care. And that is the program. Let's focus on your health. I'm TG LaFredo. Thanks for listening. We'll catch you next time.